Hello everyone, I am Dr. Mahesh Gadhvi. I am Associate Professor in Department of Physiology, AIIMS Jodhpur, and today I am going to take lecture on cardiac output. Before starting the lecture, I want to thank the Physiological Society of India and Dr. Prasun Priya Naik sir for giving me the opportunity, and I also want to thank Dr. Vinay and Dr. Ritu for hosting the session. So, the cardiac output, before understanding it, all of us knows that the heart has its main function, which is pumping the blood. So in our school days you might be knowing that our teacher tells us the heart has main function, which is pushing the blood. Okay, but how effectively the heart can push the blood or heart is pumping the blood, it is not known. So the pumping of the heart, its effectivity, it is the cardiac output. If you want to define it, it is the amount of the blood which is ejected by each ventricle in a minute. Normally right and left ventricle eject more or less same amount of the blood. So the same blood which is going from the right ventricle, it goes to the left ventricle, so its amount is more or less same. So in a minute, how much amount of the blood which is ejected by the heart, it is called like the cardiac output. So if you had attended the previous lecture of this series, you might be knowing that Dr. Nayak sir has told you that in each cardiac cycle, the amount of the blood which is pushed by the left ventricle, it is called as stroke volume, right? So stroke volume, which is amount of the blood ejected by ventricles in each cardiac cycle. And now you know that how many cardiac cycle are there in a minute, because for calculation of cardiac output we take the value in minute. So there are how many cardiac cycles are there in a minute, it is same as our heart rate. So the cardiac output is equal to stroke volume and heart rate. Normal stroke volume, it's around 70 ml, and if we take heart rate is 72 beats per minute, so the cardiac output will be around 5000 ml per minute, which is 5 liters per minute. So the normal value of cardiac output at rest in adult is around 5 to 6 liters per minute, but it can change during exercise, when the body's need are more, or when the body size is more or less, its value changes. Because in a large human being, its cardiac output or blood requirement is more, so the cardiac output will be more, but in small babies cardiac output will be less. So we have to take the body surface area into account, and the value which comes is cardiac index. So what's cardiac index? It's the cardiac output when it is expressed in relation to the body surface area. It is called as cardiac index, and the normal value of cardiac index is 3.2 liters per minute per meter square of our body area. Now that we will see what is distribution of this cardiac output to various regions. So here in this table you can see that the main area of our body, like liver, kidney, they take 50% of cardiac output. Other, if we take brain, heart and lungs into calculation, this only these five organs are taking 75% of our cardiac output. The next important topic is how to measure the cardiac output. For measurement of cardiac output, earlier this direct fixed method and direct dilution method were used, but nowadays with the help of newer technologies like echocardiography combined with Doppler, it is useful for cardiac output measurement, and it is regularly being used. So we will see each technique one by one, and starting with echocardiography. What is echocardiography? It's the ultrasonic evaluation of the cardiac function by the transducer. It is non-invasive technique. It doesn't involve any injection or insertion of catheters, which we will see there. They will be used in different techniques, but in echocardiography, no injection, no insertion of any catheter. It uses ultrasound. This ultrasound is transduced through is going through the transducer. It will reflect from different heart regions, and it is going back, and the transducer itself receives the signals, and according to that the different part of the heart is being evaluated. Different heart valves or different heart septums, these are being evaluated by echocardiography. When this echocardiography is combined with Doppler technique, This gives us values of velocity or flow of the volume which is going through the valves, and thus it is particularly used for evaluation of end diastolic volume and systolic volume, cardiac output, and any valvular defect. This can be measured by echocardiography. The other technique is fixed method. So before that, you must know what's a fixed principle. It's the amount of the substance which is taken up by the organ per unit time, which is equal to its arterial level and minus venous level. It is called as the arteriovenous difference into blood flow. So if we take the substance as oxygen, and take we will take an example where the oxygen is this substance, and so what should be the equation? The oxygen which is absorbed per minute by the lung, here in the its definition, you can see the amount of the substance which is taken by the organ is equal to its arterial level minus venous level, arterial oxygen difference, arteriovenous oxygen difference into the blood flow. Here the blood flow will be cardiac output. So this is the equation. Now in this equation we want to measure the cardiac output. So we have to shift this arteriovenous oxygen on the opposite side. So the equation will looks like this. Cardiac output is equal to oxygen absorbed per minute by the lungs divided by arteriovenous oxygen difference in the blood. So how this works? Normally in physiology we know that the blood which is coming from the vein, it goes to heart, and from the pulmonary arteries. In pulmonary capillaries, blood oxygen exchange occurs. Oxygen is consumed in the artery, going into our artery. Then from the pulmonary vein, the blood will go towards the different regions of the heart. Now if we want to measure it, so we have to measure the oxygen which is absorbed per minute by the lungs, which is measured through spirometry, and normal value is 250 ml per minute. Arteriovenous oxygen difference, for that we have to measure oxygen from the pulmonary artery and the different systemic arteries. So for measurement of oxygen PaO2 in pulmonary artery, we have to insert the catheter. It will go from the peripheral veins to the right atrium and then pulmonary artery. From there we have to take the blood collection, and we have to measure the oxygen content or PaO2 in that blood. Normally it is 14 ml per deciliter, and if we want to take arterial end oxygen amount in the arterial end, we can take any artery, any systemic artery, and suppose we are taking recording from brachial artery, it is around 19 ml per deciliter. So we have to take arteriovenous oxygen difference, which is 19 minus 14, and the oxygen absorbed, which is 250. If we put these values into it, we can get the cardiac output. This is the fixed principle where we have to insert the catheter. The other method, it is indicator or dye dilution method. It is also here also we inject some amount of indicator dye, which concentration we know previously. Then we inject into a large systemic vein, and preferably it goes into right atrium. From right atrium it passes through different heart structures like right ventricle, then pulmonary circulation, again from left atrium, left ventricle, and goes into systemic arteries. The concentration of this dye is recorded as dye passes through different peripheral arteries, and by that we calculate the cardiac output. How the graph looks like? It looks like this. So this is a reference taken from Gatton and Hall textbook of medical physiology. In this graph you can see on the x-axis it is time in seconds, on the y-axis it's dye concentration in artery, which is in milligram per 100 ml. Here you can see the dye is injected, 5 milligram of dye is injected, and that time is noted as 0 point. After that the values are taken from brachial artery, and it takes up time to record because it will pass through different heart structures and then it reaches to the peripheral artery. So it takes some time. This is the latency. After that you can see the dye concentration into artery is being recorded. It peaks after some time, and after that when the dye is going away from the artery, its concentration is going down, but its concentration doesn't reach at the zero value. Its concentration decreases and again it starts to increase. Why? because the dye is again circulating whole the circle and coming back to the recording site. So we don't want this. We want only the amount of the dye which is coming after one circle. So we have to extrapolate this line. We want a perfect curve where the curve meets the 0 point. So we can extrapolate this curve. In this second example, we can extrapolate the curve and we can touch it at the line. So this dashed line is extrapolated part. Now for the cardiac output measurement, the equation is like this. It is cardiac output, which is ml per minute, is equal to milligram of dye injected divided by average concentration of dye in each ml of blood for the duration of the curve. So for that you have to take all the recordings. Here we take 4 or 5 recordings and make a curve, and we take area under curve as an average, and we have to multiply it with the duration of the curve in seconds. So here you can see it is around 3 to 13 seconds, so it is around 10 seconds difference is there. And because its value is in seconds and we want the cardiac output which is in minutes, so we have to multiply it with the 60 number. So by this indicator dilation method also we can calculate the uh, cardiac output. Now the most important part, which is regulation of cardiac output. It must be known by all the undergraduates how the cardiac output is regulated, what are different structures which are important for cardiac output regulation. So the cardiac output, which is the byproduct of stroke volume and heart rate. So the factors which are affecting stroke volume, they can also affect cardiac output, and the factors which are affecting heart rate, they can also control the cardiac output. Stroke volume, which is mostly affected by preload, afterload, and myocardial contractility. And so we have to understand what is preload, what is afterload, and how this myocardial contractility is affected. So first we will focus on preload and afterload, how they are, what is preload, what is afterload, and how they are affecting the cardiac output. So in this image you can see that there is a muscle which is suspended. This the first part it is in resting stage, and in the second part it is in contracted stage. Now in the suspended muscle there are two weights, one is small square, one is large square. And in the first image you can see that the small square is acting on the muscle, while the large square, which is after load, it is not working on the muscle. Now here you can see that the small square, which is a preload, which is acting on the resting stage of the muscle also. So the weight or the load which acts on the muscle before it gets contracted, when the muscle is in resting state, at that time the amount of the force which is acting, it is called as preload. And when the muscle gets contracting, or muscle starts contracting, at that time the load which is acting, it is called as the afterload. So the difference, major difference between these two is when the load is acting on the muscle. When it is acting before the contraction or in the resting stage, it is called as preload, and when it's in the during contraction, it is called as afterload. Now in the heart muscle, they have to contract, and so you can guess what is the preload in that condition. It is the end diastolic volume, the amount of the blood which is going into ventricle, it is pushing the heart. It is the load against which it is to constrict. So it is the preload which stretches the muscle, and for that there is a law which is called as Frank Starling's law of the heart, which says that the within physiological limits, the force of contraction of the muscle, so here this muscle, the force of contraction of this cardiac contraction is proportional to its end diastolic volume. How much the weight is acting on the muscle, it can affect the contraction. The more it is stretched, more contraction will occur within physiological limit. It is called as a preload. So the preload, or in the heart we can say that end diastolic volume. Now we will see how this preload is affected, what are the factors which are affecting the preload. And the main part, it is through the venous return. So first we have to see what is venous return. Venous return, it's the quantity of the blood which is flowing from the veins into right atrium. Our inferior vena cava and superior vena cava push the blood from the peripheral part, or the from periphery to the right atrium, and the amount of the blood which is coming to the heart in a minute, it is called as venous return. And this blood causes is the responsible for end diastolic volume and more stretching of the heart and increase the preload. So the when the venous return increases, preload increases and the cardiac output increases, and vice versa. When it is decreases, cardiac output decreases. So we have to see what are the factors which are affecting venous return, which can affect preload, which can affect cardiac output. These are the factors like skeletal muscle pump, respiratory pump, abdominal pump, blood volume, and sympathetic activities. These are the factors which can affect venous return. We will see each factor one by one. So, starting with the skeletal muscle pump, uh, in this image, you can see that there are muscles, and in between the muscle there are veins. So normally in our calf muscles or even thighs, these veins are there in between the muscles. So these two images, the first image is contracted stage and the other image is in relaxed stage. So here in the first image you can see uh, that the blood vessels are there in between the muscles, and when the muscle contracts, these veins are squeezed, and once the veins are squeezed, blood will try to go in either direction. But because the veins have the valves, blood can go only in one direction. It cannot go in distal part. It only push towards the proximal part because the valve opens at the proximal end, right? So it's a one directional valve which helps to push the blood towards the proximal part, towards the heart, so that when the muscles are constricted, venous return increases, more blood coming to the right atrium, and so venous return increases, and because of that cardiac output increases. But when the muscle is relaxed, now the veins are relaxed, veins are dilated. Now the blood which is in the proximal part, it cannot go down because the valve stops it, and it remains in the upper part. So at last, because skeletal muscle increase the cardiac output, because one way valve helps in the unidirectional force of the blood during skeletal muscle contraction. It is very helpful, yeah, if you are walking or if you are running in the ambulatory person. It is very helpful to increase the card or maintain the cardiac output. If the patient is bedridden or the paralysis is there, this skeletal muscle pump cannot work effectively and cardiac output can change. The second part is respiratory pump. How this respiratory pump increases venous return. So during inspiration, what happens that intrathoracic pressure, it becomes more negative. Normally it is -2 mmHg, but during inspiration its negativity increases, more negative occurs, and because of that the pressure inside the inferior vena cava reduces, which acts like a suction, and more blood is coming towards the inferior vena cava. So during inspiration, one respiratory pump which causes suction like effect, and more blood is coming to the uh, from the inferior vena cava. And during inspiration, this abdominal pump also works because the descent of diaphragm occurs. Our diaphragm got constricted, it goes down, and the intra abdominal pressure increases, and because of that the blood flows from the abdominal to the right atrium. So during inspiration, both respiratory pump and abdominal pump acts. Respiratory pump causes suction like effect, abdominal pump pushes the blood from the abdomen towards the heart. Now the fourth part is blood volume. So as the cardiac output is amount of the blood, so if the blood volume increases, or increase in extracellular fluid occurs, venous return increases. If the blood volume decreases, like in diarrhea or vomiting or long standing cases, it blood volume decreases, the venous return decreases. Now comes the fifth part, which is sympathetic activity. So the blood vessels which are supplied by sympathetic nervous system, and the veins are capacitance vessels. If you know what is capacitance, it accommodate more blood. So veins are capacitance vessels which stores the blood, right? So if there is sympathetic stimulation, there occurs venoconstrictions. So vein constricts, and because of that it decreases the capacity of venous system and it pushes the blood towards the heart. So during sympathetic stimulation, the veins venoconstriction occurs, and because of that also, like skeletal muscle pump, the blood going towards the heart. So this was about venous return. Now the second part which affects the preload is atrial systole. Now here in this image you can see that the blood which is coming into the left ventricle, it is right ventricle, it must come from the atria, right? So first blood comes in the atria and then into ventricle. And in the cardiac cycle part, we know that the atrial systole which lasts from only zero point 0.1 second and zero point 0.7 second it is only diastole. So during before atrial systole, the 75% of blood is already flowing from the atria into ventricle, and only 25% blood is at last in zero point 0.1 second is pushed by the atrial contraction. So when the atrial contraction occurs for zero point 0.1 second, it pushes 25% of the blood into the left ventricle. When the atrial contraction occurs effectively, the blood into left ventricle is more. When the atrial systole is dysfunctional, at that time the venous return, or sorry, atrial systole is defective. At that time, cardiac output, or we can say end diastolic volume, is decreased. Uh, After that, after atrial systole, the effective part is ventricular compliance, which can also affect preload. So these ventricles are stretchable. Okay, so more the end diastolic volume is, the more we know that according to Frank Starling's law, more the muscle contraction, muscle stretch, more the its effective contraction will be. So in some pathological condition, this stretchability is decreased, like in pericardial effusion or in cardiac tamponade, where the muscle stretch cannot stretch more. So end diastolic volume cannot go on the higher values. So at that time also the cardiac output can be decreased. This was about preload. Now we will see what is afterload. Afterload is the resistance against which the blood has to push. So the force, the load which is coming into effect after the ventricles are contracting. So it is total peripheral resistance, resistance which is offered by arterioles. It is your afterload. So this afterload is affected by two things. It is affected by vessel diameter as well as blood viscosity. This cardiac output is inversely proportional to the afterload. So when there is vasoconstriction, or when there is increased total peripheral resistance, at that time the afterload increases, and because of that the cardiac output decreases. As well as when the blood is very thick or blood viscosity is increased, like in polycythemia, at that time also the heart has to force more to pump the same amount of the blood. So if the viscosity increases, afterload increases, and because of that cardiac output can decrease. The disease is polycythemia, in which blood viscosity is increasing. The last part which affect the stroke volume is myocardial contractility. Uh, it can be affected by ventricular muscles contractility, autonomic activity, and different hormones. In this image, you can see all the factors which are affecting myocardial contractility. So, in state of hypoxia, hypercapnia, or acidosis, the cardiac myocardial contractility decreases. In the red color, you can see the arrows in the red color is decreasing the myocardial contractility. During sympathetic stimulation, uh, the cardiac contractility increases. Like that, catecholamines acts on the myocardial increase myocardial contractility. Xanthines, glucagon, digitalis, they all increase the contractility. But the parasympathetic stimulation, or in the case of heart failure, in case of myocardial infarction, or some drugs like quinidine, prosenamide, barbiturates, they decreases the cardiac myocardial contractility. So all these were the factors which were affecting the cardiac output by decreasing or increasing stroke volume. This was the one part. The second part is the heart rate. The factors which can affect the heart rate can also affect the myocardial output, and the most important is autonomic activity. Sympathetic or parasympathetic stimulation can also increase or decrease cardiac output. But here you can see that when the heart rate is increasing, in this lower part, the stroke volume is decreasing. and because of that mostly the cardiac output remains same. So it's not always that heart rate increase in heart rate will change the cardiac output. No, heart rate increases, at that same time stroke volume is also adjusted to maintain the normal value of cardiac output. Why? Because when the heart rate increases, the duration of cardiac cycle decreases. So the heart has less time to accommodate more blood. So end diastolic volume decreases, and once the end diastolic volume decreases, the stroke volume also decreases. So this is normally occurring, but during exercise, when we do exercise, at that time heart rate increases, but along with it, to maintain the increased need of the body, the stroke volume also increases. So during exercise or strenuous work, our heart rate increases, and because of that the cardiac output is also increases. This was about cardiac output. First we saw about what is cardiac output, then we focused on the measurement of cardiac output, and at last we saw different factors which are affecting, and in factors also stroke volume and heart rate. This was all about cardiac output. Thank you again. Thank you for the Physiological Society of India for giving me opportunity.